Welcome back to the deep dive. Today we're jumping into something called pulmonary hypertension, PHTN for short. Sounds a bit complex maybe, but
Mm.
it's really key for understanding, heart and lung health in our dogs and cats.
It is. Basically, think high blood pressure, but just in the arteries going to the lungs.
Okay.
And when we say elevated, well, we have actual numbers for that. In the main lung artery, we look for a peak systolic pressure. That's when the heart contracts above 30 millimeters of mercury, or a peak diastolic when the heart rests over 15. Those are the thresholds we watch for.
Okay, numbers. I know sometimes that can seem a bit much,
Hmm.
but don't worry. The whole point of this deep dive is to break it down. Make PHTN well, make it make sense for everyone listening. We really want to get into what causes it, how you'd spot it, and importantly, what can actually be done. The essentials.
Exactly, the practical stuff, without getting too lost in the weeds.
Right. So should we dive into the how it works part first, the sort of mechanics behind it?
Yeah, let's do that. The pathophysiology. It helps to understand why the pressure goes up. There are basically four main ways this happens. First up is pulmonary arterial vasoconstriction.
Okay, vasoconstriction.
Mhm.
So the blood vessels in the lungs are actually squeezing tighter.
Exactly, like pinching a hose. Less space, more pressure for the same amount of flow.
Got it. What's number two?
Number two is pulmonary arterial obstruction. So something is physically blocking the vessels.
Like a blockage in the hose itself.
Precisely. Third is high pressure in the left atrium. That's one of the heart's chambers. If the left side of the heart isn't pumping out blood efficiently, pressure backs up into the pulmonary veins, then the arteries.
Ah, like a traffic jam backing up from the main highway onto the side roads.
That's a great analogy, yeah. And the fourth reason is simply too much blood flowing through the lungs, just excessive volume.
Okay, so constriction, obstruction, back pressure, or too much flow.
Hmm. And no matter which one starts it, the result is the same. That pulmonary artery pressure goes up. And that means the right side of the heart. Its job is to pump blood into those arteries. Well, it has to work much, much harder.
Right. And I imagine that constant extra effort takes a toll.
Absolutely. Over time, you can get right ventricular dysfunction. The right ventricle just gets worn out, less efficient. And here's an interesting loop. If less blood gets pumped through the lungs by that struggling right ventricle, then less oxygenated blood gets back to the left side of the heart to be pumped out to the body. So overall, cardiac output can drop.
Wow, so a problem starting on the right side because of the lungs ends up affecting the left side and the whole system.
It's all connected. Plus, that high pressure on the right side can cause blood to back up in the veins leading to the heart. This can cause the tricuspid valve to leak, that's tricuspid regurgitation, and potentially lead to right-sided congestive heart failure, RCHF.
Or CHF. And you mentioned this isn't just a heart-lung issue. It spreads.
That's really important, yeah. RCHF means fluid backup. That affects the liver. You get hepatic congestion, maybe impaired liver function. And of course, the respiratory system is involved beyond just the initial cause. RCHF can cause pleural effusion.
Fluid building up around the lungs.
Exactly, making breathing even harder. So it hits cardiovascular, hepatobiliary, and respiratory systems.
Okay, that paints a clear picture of the consequences. Let's circle back to the triggers. What actually causes these problems? You mentioned four mechanisms, but what are the underlying diseases?
Right. So one big category is pulmonary parenchymal disease, problems in the lung tissue itself.
Okay.
This could be scarring, like fibrosis or tumors or inflammation thickening the vessel walls. These can cause obstruction.
And specific lung conditions.
Oh, definitely. Think about pneumonia, bacterial, viral, fungal, parasitic chronic bronchitis, pulmonary fibrosis. Also things like eosinophilic bronchitis, lung cancer or ARDS, acute respiratory distress syndrome. Many of these cause low oxygen levels, hypoxia, and acidemia.
Which triggers that vasoconstriction we talked about.
Exactly. The body tries to shunt blood away from the poorly functioning parts of the lung, but it ends up raising the overall pressure.
Okay, that makes sense.
Okay.
What's another major cause category?
Pulmonary thromboembolism, PTE, blood clots.
Ah, clots getting stuck in the lung arteries.
Yep. They cause direct obstruction, obviously. But they also trigger vasoconstriction, partly due to hypoxia and partly from substances the clots release.
And does PTE just happen, or are there risk factors? The sources mentioned some.
Usually there are underlying reasons, things that make clotting more likely. Cushing's disease, for instance, or conditions where pets lose protein through their kidneys, or gut protein, losing nephropathy or enteropathy. Also sepsis, severe infections, immune-mediated hemolytic anemia, IMHA, cancer, pancreatitis, heart valve infections, DIC, which is a widespread clotting problem, even sometimes primary right heart disease itself can predispose to clots.
Wow, quite a list. It really highlights PHTN as potentially a sign of something else systemic going on.
It really can be, yeah.
Okay, next up, heartworm disease. How does that fit in?
Well, heartworms live in the pulmonary arteries. So the worms themselves cause physical obstruction, but the body also reacts to them. You get inflammation, the vessel walls thicken hypertrophy, and you can get secondary blood clots forming too.
And again, hypoxia and clots lead to vasoconstriction.
Plus, the inflammation itself contributes. And definitely, as you'd expect, PHTN due to heartworm is much more common in heartworm endemic areas. That geographical link is strong.
That makes sense. What about heart problems someone's born with? Congenital heart disease.
Right. Certain defects cause what we call a left-to-right shunt. Blood flows abnormally from the higher pressure left side of the heart over to the right side and floods the lungs.
Okay, so too much flow.
Yeah.
Like that fourth mechanism you mentioned earlier.
Exactly. That constant excessive flow damages the pulmonary vessel lining over time. This leads to thickening, constriction, obstruction. The vessels try to adapt, but it backfires.
And examples of those defects.
Things like a PDA, patent ductus arteriosus, or a VSD, ventricular septal defect, or an ASD, atrial septal defect.
Gotcha. So a plumbing issue from birth leads to lung vessel problems later. Now, what about acquired left heart disease? Seems like a direct link.
It is pretty direct. If the left side of the heart is failing, maybe due to a leaky mitral valve, mitral regurgitation, or cardiomyopathy, which is heart muscle disease, pressure builds up in the left atrium. That back pressure extends straight into the pulmonary veins, then the arteries. Pulmonary venous hypertension first, then arterial.
And that pressure itself causes damage and constriction.
Yes, exactly. High pressure leads to vascular remodeling, thickening, just like with the shunts. Other causes could be mitral stenosis, rare congenital issues like cor triatriatum sinister, or even left atrial tumors.
So basically, anything that makes the left heart struggle can cause backup into the lungs. And the last category, extrapulmonary causes of chronic hypoxia.
Right, meaning low oxygen for reasons outside the lungs. If an animal isn't breathing effectively, hypoventilation, maybe due to severe obesity like Pickwickian syndrome or neuromuscular problems, that chronic low oxygen triggers pulmonary vasoconstriction.
And altitude.
Yes, living at high altitude is another key one. Less oxygen in the air means chronic hypoxia, leading to vasoconstriction. Another geographical factor to consider.
It's amazing how many different roads lead to this one condition. What about genetics? Is there like a PHTN gene in dogs or cats?
Not really, not a specific gene for primary PHTN like we sometimes see in humans, but and this is important. Some of the underlying causes, like certain congenital heart defects, definitely can have a genetic basis.
Okay.
And there's maybe some suggestions, some studies hint that terrier breeds might have a higher incidence, but that could just be because they're more prone to some of the underlying lung or heart issues that cause PHTN.
Right, so it's more about the predisposing conditions than PHTN itself being directly inherited.
Yeah.
Okay, so now we know the what and the why. How do we spot it? What signs should people look out for?
The signs often relate back to the low oxygen, the hypoxia, and the heart struggling. So a big one owners notice is exercise intolerance. Their pet just gets winded really easily.
Okay, that seems like a clear warning sign.
Definitely. Also, difficulty breathing dyspnea or rapid breathing tachypnea. Coughing is common too.
Coughing, even blood sometimes.
Yes, hemoptysis, coughing up blood, can happen, though it's less common. Fainting spells, which we call syncope.
Fainting, wow.
Yeah. Abdominal distension, like a swollen belly, usually from fluid buildup, maybe weight loss, just general lethargy, low energy. And unfortunately, in severe cases, sometimes sudden death is the first sign.
That's scary. So what would a vet look for during an exam?
Well, they'd observe the breathing, obviously, listen for abnormal lung sounds, crackles, harsh sounds, listen to the heart. Sometimes the second heart sound is louder or split.
Sound.
Yeah, the timing of the valves closing changes. They might see cyanosis, that bluish tinge to the gums from low oxygen. A heart murmur could be present from the underlying cause or the tricuspid regurgitation.
And other physical signs.
Checking for that abdominal distension ascites, looking at the jugular veins in the neck, are they distended? Feeling for swelling under the skins, subcutaneous edema, noting weight loss or poor body condition.
So a lot of clues, but they overlap with other things, right? Diagnostics must be key.
Absolutely crucial. You start with baseline tests. Blood work, CBC, chemistry, urinalysis.
How those show?
You might see polycythemia, too many red blood cells, the body's attempt to carry more oxygen. Or a high white count, leukocytosis, suggesting infection. Maybe hints of a clotting tendency, which points towards PTE.
And beyond the basics.
Arterial blood gas analysis can directly measure oxygen levels, confirming hypoxemia. A heartworm test is vital, especially in certain areas. If you suspect PTE, you might run more specific tests: urine protein-creatinine ratio, antithrombin III, D-dimers, coagulation panels, maybe endocrine tests for Cushing's.
What about fluid analysis?
If there's effusion fluid in the belly or chest sampling that fluid, cytology can give clues about the cause.
Imaging must be huge here. Chest x-rays.
It's very important. Radiographs can show if the main pulmonary artery looks enlarged or twisted. Is the right side of the heart enlarged? Is the vena cava dilated? Is there fluid, liver enlargement, ascites? Plus, you look for evidence of the primary problem, lung disease patterns, signs of heartworms, maybe even suggestive signs of PTE, although x-rays aren't great for definitively diagnosing PTE.
Okay. But the real star seems to be echocardiography, the heart ultrasound.
Echo is definitely central. It lets us see the heart structure and function directly. We look for right ventricular hypertrophy, thickened muscle wall. Is the septum, the wall between ventricles, flattened because of the high right-sided pressure? Is the right atrium dilated? Pulmonary artery dilated? Is there fluid around the heart or lungs? Can we see signs of left heart disease, heartworms, a congenital defect, or even a thrombus?
And you mentioned specific Doppler findings.
Yeah, the pattern of blood flow out of the right ventricle can look abnormal, asymmetric, sometimes notched. That's a clue.
And echo can actually estimate the pressure, right?
Yeah.
You mentioned severity grades.
Exactly. Using Doppler, we measure blood flow speeds. If the tricuspid valve is leaking TR, we can use the speed of that leak and the modified Bernoulli equation to estimate the pressure gradient between the right ventricle and right atrium. Assuming no pulmonic stenosis, a gradient over 35 millimillar Hg suggests PHTN.
And the grades?
Roughly 35 to 50 millimillar Hg is mild, 51 to 80 is moderate, and over 80 is severe PHTN. We can do something similar if the pulmonary valve leaks pulmonary insufficiency, or PI. A diastolic gradient over 15 millimillar Hg there also points to PHTN.
That's incredible detail without being invasive. When might you need more advanced imaging, like CT or MRI?
Those are really useful for looking closely at the lung tissue itself. If you suspect a tumor or some kind of infiltrative lung disease that's hard to see well on X-ray, CT, or MRI can be very helpful.
And sometimes you need actual samples.
Yes. If primary lung disease is high on the list, procedures like a transtracheal wash or bronchoscopy with a wash, BAL, or even a lung aspirate or biopsy might be needed to figure out the exact type of lung problem.
What about an ECG? A heart tracing?
ECG can show supportive signs of right heart enlargement or strain things like a right axis deviation, deep S waves, P pulmonale pattern, sometimes ST changes, or even arrhythmias caused by the low oxygen. It's supportive, not diagnostic on its own for PHTN.
And the gold standard, cardiac catheterization.
Yes.
Why isn't it routine?
Catheterization, where you thread a catheter into the pulmonary artery to measure pressure directly, is the most accurate way. But it's invasive, carries risks, needs special equipment and expertise. Since echo gives us so much good information not invasively, cath is usually reserved for really complex cases or when the diagnosis is still unclear after everything else.
Makes sense. It's a multi-step process to confirm PHTN and figure out the why. You also mentioned differentials, things that look similar.
Yeah, crucial not to miss those. Left-sided heart failure can cause similar breathing issues, collapsing trachea, primary lung disease without PHTN yet, heartworm disease without severe PHTN, fluid or air in the chest from other causes, even laryngeal paralysis, lots of overlap in signs.
So careful workup is essential. Okay, let's pivot to management. What can be done?
The absolute cornerstone is treat the underlying cause if you can identify it, and if it's treatable. That's priority number one.
And supportive care.
Vital. Severe cases often need hospitalization, maybe oxygen therapy initially. Medical treatment depends heavily on the cause and severity. Diagnostics continue as needed, depending on stability. And keeping stress low is really important for these guys.
How about things like fluids?
Tricky. Judicious fluid therapy might help improve lung blood flow in some cases, but you have to be super careful not to push them into congestive heart failure if the right heart is already struggling. Low-stress environment is key, both in hospital and at home.
And owner education.
Hugely important. Owners need to understand the prognosis is often guarded. They need to know about avoiding triggers, extreme temperatures, secondhand smoke, high altitudes if possible.
What about surgery?
Really only relevant for severe heartworm cases where surgical extraction of the worms might be considered.
Okay, let's talk medications.
Mhm.
Oxygen first.
Yes, oxygen is first line for acute hypoxia. It helps get oxygen levels up and can cause some mild pulmonary vasodilation too. Long-term home oxygen is challenging though.
Right, and the PDE5 inhibitors. Sildenafil, Viagra.
Yeah, sildenafil is the most commonly used one in dogs. It works by increasing nitric oxide signaling, which relaxes and dilates those pulmonary arteries, lowering the pressure.
Emmy catches.
Big one. Don't use it with nitrates like nitroglycerin. That combination can cause severe, dangerous drops in blood pressure. Tadalafil, another PDE5 inhibitor, has shown some potential benefit in pets too. Vardenafil, not really studied.
Okay. What about other vasodilators?
Things like ACE inhibitors, hydrolysine, calcium channel blockers, they tend to lower systemic blood pressure too much, which isn't always helpful and can sometimes worsen things in PHTN unless the PHTN is caused by left heart failure. Then they might be part of that treatment plan.
Got it. And Imoventin. That's common in heart disease.
Timobendin helps the heart muscle contract better and is also a vasodilator, both systemically and in the lungs. It's definitely indicated if the PHTN is secondary to left-sided heart failure, like mitral valve disease. Its benefit for other causes of PHTN is less clear.
Bronchodilators? For airway issues.
Yes, if there's underlying lung disease like bronchitis, drugs like terbutaline or theophylline can help open the airways. Theophylline also has a mild pulmonary vasodilating effect itself.
What about blood thinners or clot busters? Anticoagulants? Thrombolytics?
Anticoagulants are standard in human PHTN related to clots, but their role in pets is less defined unless you've actually confirmed a PTE. Thrombolytics clot busters like TPA are pretty controversial, maybe considered only in really acute, life-threatening PTE with severe heart compromise, but it's risky.
And anti-inflammatories or antibiotics?
Steroids might be used if inflammation is a big part of the picture, like with heartworm reaction or certain lung diseases. Antibiotics, obviously, if bacterial infection is suspected or confirmed.
So medication choice is very tailored. Are there drugs to absolutely avoid?
Definitely. Respiratory depressants are bad. They worsen hypoxia. Myocardial depressants like beta blockers usually aren't good unless treating a specific underlying issue. Bronchoconstrictors are out, and anything that causes vasoconstriction needs to be avoided.
And precautions when using the treatments.
Monitor for low systemic blood pressure with the vasodilators. Watch for excitability or fast heart rate with bronchodilators. And, critically, avoid dehydration. Hypovolemia can actually decrease blood flow through the lungs.
Once treatment starts, how do you monitor progress?
Regular follow-up is key. Serial echocardiograms are probably the most important tool to reassess pulmonary pressures and heart changes. Repeat x-rays, ECG, blood work, blood pressure checks as needed based on the individual case.
And even with treatment, there can be complications.
Unfortunately, yes. Progression to right-sided heart failure is a major concern. Syncope, arrhythmias can still happen. And sadly, sudden death remains a risk in severe cases.
It really drives home that PHTN is serious and complex.
It is. The outcome really hinges on the underlying cause and how effectively we can manage that. So overall, the prognosis has to be considered guarded in many cases.
Well, this has been incredibly thorough. We've really unpacked pulmonary hypertension, what it is, the huge range of potential causes, the signs, the diagnostics, and the management approaches. It's clear it's complex, but also clear that identifying and tackling that root cause is absolutely fundamental.
That really is the take-home message. An early diagnosis and addressing the primary disease gives these pets the best chance, even if the road ahead is challenging. It's about managing the condition and maximizing quality of life.
Absolutely. And that leaves us with a final thought to ponder. We've seen how PHTN can be triggered by so many different things: infections, clots, heart defects, lung disease, even where you live. So, thinking broader now, what other, maybe less obvious environmental factors or lifestyle elements might be subtly influencing cardiovascular health in our pets that we haven't even considered yet? Something to chew on. Thanks for joining us for this deep dive.